All right. Hey, Mark, thanks for meeting me today.
Glad to do it.
Could you share with me a little bit about your background and sort of how you came to work on this COVID project?
Sure. I'll give you a very abbreviated version. I grew up in Chicago, died in the wool Chicagoan. Much to my surprise, my life led in directions that I couldn't have predicted. And I wound up in the National Service Corps in Yuma, Colorado, population 2,000, as a family doctor. And I started out in pediatrics, and I was, there was kind of nothing about what I wound up doing that was predictable, which was nice because it left a little question about whose life I was actually living. And I fell in love with the prairies and the people and with family medicine. And so I did a practice for 5 years, a private practice in Ripon, Wisconsin. Came back here in '85 and have been in Greeley ever since. I came to work on the faculty of the residency, as a family practice residency teaching program, and I've done a lot of other things also during this time. That's also when I got involved with CAHEC. I was, as part of my duties of the residency, my job was continuing medical education, and which was a natural thing, natural combination with AHEC, with CAHEC and with the AHEC mission at the time. Continuing medical education was also something else that I just fell into. It was nothing that I planned. And so I've been on the board at least a couple of times. I was even an employee for a couple of years when there was a grant that had regional medical directors a long time ago. And I've been back on the board since, I think, just 2018, this time. So, I'm a long time believer in the importance of rural health care, a lover of those people and those places, and tried to be an educator. In my time at the residency, I put together the rural training track program and alternative training track program. So one is at the Community Health Center here in Greeley, Sunrise Community Health, and the other's in Ray, Colorado, and it's still going, and it's been going since 1992. And as far as I know, it's the smallest town in the United States with full-time graduate training program in medicine. I've written about telehealth, I've written about technology in medicine, all with an eye toward really how do we support the people in the boonies? And technology is a large part of that. I've been a teacher. I was medical director of hospice here in Greeley for a few years. So I've done lots and lots of stuff, but I keep on coming back to rural and to family medicine. And so, of course, CAHEC is a perfect fit. Now, how did I wind up doing this? Well, because you asked me to. This was your idea. This project was your idea. It was a terrific idea. I saw that right away and I said, sure, whatever I can do. I had a retirement party 10 years ago, which I highly recommend. It was a lot of fun, but I've never really retired. And this is what I'm doing most of now in terms of in a professional direction. I'm not seeing patients anymore. I haven't for a while. But this is really important. Giving voice to the people who were so often overlooked, and making a record of such an unusual time in our history for use. I have lots of thoughts about how we could use that, or how that could be used. So that's it. Here I am.
Well, I appreciate that you're always supportive of our ideas and ways to move the message forward about what are the challenges and the constraints in a rural area. But when you and I first started talking about this, I think in my mind, we were going to do one thing. We were going to just get some information. But over the course of the last 3 months,
Mm-hmm.
do you feel like these stories have gone someplace else? And what's happening with the information that we're getting? Just
Yeah. It's like so many other things I've participated in. Whatever it is that you're providing or reaching out with or doing affects the reachers and the providers as much as the people you're reaching. I feel there are 5 of us, I believe, who've been doing interviews, and we've all been affected by it. We've been affected. I tell people this is the best thing I'm doing these days. We've been affected just by the connection that we've had. And especially at a time when we're all sequestering, to be able to connect this way has really been important to all of us. As far as what messages I've heard, well, I've learned some pretty interesting things about how people are coping. The fact that there are a variety of different ways and that some of them are really pretty interesting and pretty creative in themselves is no surprise to me. I mean, we all know that's how people are, and that's how rural people are, getting along with reduced resources. So no surprise there. Just it's been very fulfilling and affecting things to do. We were talking the other day, you and I, when I interviewed you, and you were saying doing 3 of these a day was too much. It was exhausting, and it wore us out. Another thing that especially in my interviews that I've been asking about a lot is the use of telecommunications technology, of telehealth, or even just these Zoom. You recall I published, I think, I co-authored a book in 1989 on telemedicine. And I've recently written a blog entitled I was into telemedicine when telemedicine wasn't cool, or something like that. It's the big question back then was even, why isn't there more of it? And so it's very good to see things now that have always made sense actually happening, and to see where the both the benefits and the challenges are of doing so many things this way. There's a Chinese proverb, may you live in interesting times. And it's never been made clear whether that's for me, just the way I'm constructed, it's a blessing. These sure are interesting times, and we've got so much to learn and so much to embrace. And I thank you for the opportunity to do it via this program.
in a way, or as an unintended consequence, are these interviews helping you cope with what's going on?
Yes, they are. I mean, just feeling some more connection, feeling less isolation, staying in touch with, the people and places that I love, certainly helps. Getting to talk heart to heart. And there's something about this medium because, we can't fake it, you and I. We're looking into each other's cameras or video screens. And so we're really paying attention to each other when we do these. That's good for you in any situation. So yeah, I think it's helped me.
Have you been surprised at some of the responses that we've gotten along the way?
Actually, some of the things are very creative that I've heard of what people are doing and how they're coping. I've not been particularly surprised because, even just the people whom I would know, and I know lots of people from our service here, from the CAHEC service area, there are people who are really doing it. That's one of the reasons why we still have a relationship. They're the people who, when they hear the distress call, run toward the accident. So I've heard so many different ways that people are helping and doing and chipping in and contributing, and so much creativity around it. But that doesn't surprise me.
Talking about contributions, we've spoken to healthcare providers who have been in the workforce. We've spoken to some who, because of this event, they came back to the workforce. And do you feel that there's an overall sense of guilt for healthcare providers if they're not just jumping in and they're sitting on the sidelines a little more? I mean, do you feel guilty? You're not being the doc, even though you are to me when I say, "Hey, Mark, look at my bone."
Yeah.
Is there guilt?
Not guilty. It's not guilt, but I had the feeling of, I trained at Cook County Hospital in Chicago, which had about as many beds as Yuma, Colorado. And it turned out to be a very good place to train, surprisingly for rural care, because it was also low resourced. You had to depend on yourself a lot. And I chose to work there because I felt inspired to care for those who most needed it. When this came around, not guilt, but frustration that I wasn't there on that, because also that was the closest I've ever been with the people I work. It's like how people talk about their World War II platoons, the people they have connected with so closely. Well, that's how it was at County, because we were all on the front lines fighting the good fight against disease and death. And when this came around, and here I was sequestering in my comfortable home, I didn't feel guilty about it, but I was frustrated. I felt I'd like to do that. I did volunteer to be a case, what do they call them? They used to call them caseworkers, but the people, epidemiology, the people who track down cases. And I did volunteer to do that, and nothing's come of it. I think it would be very interesting, and it's important work. I dole out a lot of advice to friends and family about how to manage.
Two questions. Where do you get your information?
Oh, good question.
And how do you know that it's the right information to share with others?
Well, I read a lot, and I read all the time. And I can't say, there are some places, of course, that are more reliable. But you have to understand, this is a situation where nobody knows enough. That's generally true in medicine anyway, which scares the hell out of lay people. But that's pretty much the truth anyway. We never know certainly everything about anything. But there have been so many questions about the behavior of the virus and the contagiousness of the virus, and the longevity of the virus and different kinds of surfaces, and all that kind of stuff. That's still not clear. I have come across a few good, very sensible articles. I'm sure I've sent them to you too, that just say, as we're coming out of this, what are some sensible ways to behave. I mean, we know that there's no way to reduce the risk of anything to zero, I mean, driving your car to the grocery store. Well, you don't not go to the grocery store. And I'm not talking about COVID. I mean, just driving your car to the grocery store in normal times. So how do you lower your risk to an acceptable level, whatever that is? And I mean, I have a friend who microwaves his newspaper every day before he opens it up. I mean, he's a little, he's a little crazy. So when I come across things that look to me like, based on all the stuff I've ingested about this, I send that to everybody I know. Because I also think that aside from a second wave of virus, which already seems to be happening in some places where they open too early and too fast, I think we're going to have a second wave of anxiety over this because it's sort of like it's easier just not to, it's easier to fast for a day than it is to eat sensibly for a day. Because you say, okay, I'm just not going to eat. I don't have any decisions to make. Well, when we were all sequestered, there weren't a lot of decisions to make. Do I microwave my paper or not? But as we come out of this, how do I re-encounter the world? I think is going to cause a whole lot of, I mean, already there are public fights over whether you're wearing a mask or not. And I've heard from both sides disdain over people who are or aren't if you're on the other side of that fence. So I think we're in for a whole lot more, which is not answering your question, where do I get my information? But the answer is from a whole lot of places. Most of them, it's almost all medical stuff. And when friends encounter good articles, they send them to me. But I don't have any one place where I look. And that's one of the questions I've asked the providers whom I've interviewed for this. And they all pretty much have professional organizations that have been really, whether they're working in nursing homes or they're family doctors or they're part of a big medical system, they're all getting very good advice from very good experts who are distilling it for the people in their system, in their profession. So I think it's easier for them, of course, than the public in general.
Let's talk about the public. When you were talking about resources, I didn't hear you talk about the CDC. I didn't hear you talk about the World Health Organization. I didn't hear you talk about the local health department. What would you tell one of your patients that came to you and said, I'm afraid? Where do I go?
Well, as you know, especially like here in Weld County, for example, there's all kinds of conflicting advice. And even if each of these lists of do's and don'ts is distilled down for the layperson, they don't all say the same thing. One of the points I make in my writing about technology is that we are now all flooded with so much information. I mean, when I go in to buy a car, I can go in and see pretty much exactly what the dealership paid for it. Or if it's a used car, what's happened to it. So I go in armed with so much more information than I used to when I go to do that. Well, the same is true of patients, and it's even true among physicians. When I talk to a specialist, I can get a much better idea of what my question is and what they're going to say than I used to be able to, because all that information is available to me. I don't go, I'm not a specialist, and I don't go to the literature and read the studies about whatever the problem is and try to make sense of it all. Because literature doesn't always agree anyway. So what I have to do is I have to find good review articles and people whom I trust who are in that specialty who can put it in context. Well, that's what I do as a family doctor for my patients. Because even, you know, you can read the CDC, you can read the World Health Organization, you can read the Weld County Health Department. God forbid, don't read the commissioners. And it's still, you need somebody to put it in context. That's what we've been losing in medicine. That's, you know, that's what I preach about all the time. It doesn't mean that you have to go see a family doctor about everything that happens. But I tell people, I send around stuff that looks really good, and I tell people, ask me. You know, one of my 3 children went back to work a month ago at a warehouse. The others were able to stay at home and do their work from home. She was in a different situation. I didn't give a blanket answer to and I love them all the same, but I didn't tell them all, stay home, it's too dangerous. It had to be put in context of their lives. And then they had to decide.
If you were still practicing, and knowing you, you might just decide to start practicing again tomorrow. But if you were still practicing, how would this event change the way you administered healthcare and practice your leadership?
Well, one thing is I'd be using a whole lot more video again, and especially, you know, it was a big decision when the government finally said that they would pay for telephone encounters. I mean, you know, how much of my time and expertise did I give away when I was in practice, doing stuff that I couldn't bill for? Or how often do people tell you? Did doctors tell people to come into the office because that way they'd get paid for what they were doing? So one thing is I'd be doing a lot more just plain telephone and video care, and, you know, try to have a very sensible way of navigating those choices. And I'd probably be writing about that too. So that's one thing that would be really different. I mean, of course, it's interesting when my friend Nancy went to see her doctor for preoperative workup about a few weeks ago, and she got to the doctor's office, and the doctor said, "This is probably the safest place on earth for you to be because they clean it thoroughly, completely 3 times a day. There are 3 people in the waiting room, and they're all sitting far apart. We all wear protective equipment, which is true, you know. And so, if I were practicing in the midst of this, we'd do that. I'd be seeing patients, I know, but I'd trying to apply practical measures for the face-to-face. What makes sense, you know, short of microwaving my paper charts.
So we've agreed, no microwaving a chart. But
especially not if they have paper clips.
Yeah, exactly. So we've all learned through this process, and we now have a big question in front of us because we're educators. What do we do with the stories? I mean, your story, my story, all the stories that we've collected. How do we memorialize the genuine conversations so that it can make a difference and it can lead to better things? What do we do, Mark?
Okay, well, I've been thinking about this since you mentioned it a couple days ago. Here's what I think. I've been all along, arguing for gathering a lot of raw data and not doing too much editing, hardly any editing, for example, and having all that and having it all available, because who knows what use it could be put to. On the other hand, and I don't think we're in a position to, we're too close to it to draw conclusions, to make points. We could make some points about, rural care and how it's different and so on. But I think the most important, that the other thing we can do with this, which is processing it, would be to create shorter videos which have a lot of captured pieces from the raw material that are used mostly to make people aware of this is here. And it could be used also to put forth the mission of AHEC. It could be used nationally to put forth the mission. So, but I see these much more as sort of marketing pieces, but without bludgeoning people over the head with, aren't we wonderful and aren't rural places great? But with the idea of piquing people's interest, and not only that, but doing it in such a way that it's not forgotten. Where do we insert it into the places in the culture, into the repositories in the culture, so that 10 years from now or 20 years from now maybe, or whatever, people know what's there, and they can look at these and say, oh, this gives a flavor of what's in there. I really do want to delve deeper. The other thing I think we ought to do, I'm not sure how to do this, would be a good index, a good cross-reference thing, by profession, by where people are from, by issues raised, and so on, and have that go along with this. Because it would be daunting how many gigabytes do we have already. So I think that's what we need to do, is one, have a big repository that's available and easy to use and indexed well, and then have some marketing pieces and ways to insert it so that people know it's there, and it doesn't just, well, you don't gather dust, I guess. It doesn't gather stray electrons, over the years. So that's my idea.
I think those are wonderful ideas.
One more thing, and also so that it's available to people who want to use it for whatever their projects are. Like, if they're doing something about rural healthcare or whatever, they can take some of our pieces and make that. Yeah.
Who do you think most needs to hear these stories?
That's a big question. So, having grown up in Chicago, I understand and you do too, having grown up in Eaton. Is that where you grew up? Was it Eaton?
I'm kind of from all over, but
all right, but rural, and having grown up in the boonies. We both understand, I wasn't aware of it, the just sort of natural, the underlying prejudice there is against rural people, rural ways. So I'd love to see like a piece that went to city slickers. But that's such a huge, it's like what we're dealing with systemic racism these very days. Where does one begin? So you could watch a little movie and that would be nice, and oh geez, aren't those people nice? I think it needs to be seen by rural people. And here's why. in some of the educational endeavors I've done, which are where we would be hooking up rural and urban things together, which we did a lot. We've done a lot. And I was always careful to make it clear, and I'd sometimes have to convince my rural colleagues of this, that we have as much to teach them as they have to teach us. We have to respect how amazingly well we do. So I think as far as just a general audience, rural, and also, whomever they are, whether they're the sociologists or historians or whatever, who want to say, here's how it went. Here are their strategies.
So we've talked about how these interviews have been difficult for us.
Mm-hmm.
But on the other end, the feedback I've gotten from people who participated in the interviews is that it's been very beneficial, almost cathartic, if you will.
Mm-hmm.
Are you getting that same sense?
Oh, yes.
Why are we getting that? Why?
Well, I think it's as simple as, it's something I alluded to earlier, having somebody listen to you. It's good for you. This situation is special and especially stressful, but it's always good to have somebody sit down and say, I'm just looking at you, and I'm going to really listen to what you say. And especially, like I said, in the context of a time that's fraught with anxieties and uncertainties, it's even better.
Have you been surprised at how raw the information has been?
How raw did you say?
Just how raw and very unpolished.
Oh, yeah, I think so. One interview, not. I got it wasn't a sales pitch, but I got a PR piece about how great their institution was doing. But other than that, no. People have done the same thing. They've looked me in the eye and we've had a conversation and they've said, this is how I feel and this is what's happening. And I haven't felt that any punches have been pulled. Yeah.
Based on everyone you've spoken to, do you have confidence in what's happening in the healthcare system? Are we in really bad shape?
Oh, listen, we've been in bad shape since I was in medical school, and I started in 1970. I mean, it's true. When I was in medical school, the healthcare system accounted for, I think, about 7% of the GNP, which was the largest in the world, of the largest GNP in the world. And now we're approaching 19%, and it's just as crazy. It's here. And I think that's another thing that's happened during this time, is it's made so obvious the holes in the system and the people who can't get the care that they need. I mean, I've known that since I chose to work at Cook County Hospital. I don't see simple reforms changing much. I think as long as we have a system that's driven by the profit motive, it will always be gamed to generate the most profit. And if you call it margin because you're nominally a nonprofit, it's the same thing. That's what drives the whole system. I've told medical administrator friends that I was glad I had an easy job. I just had to do what I thought was right. Whenever they look at any kind of a project, they can't start out by saying, okay, what's the need? They have to ask the question at the same time, what's the need that can generate a profit or margin? They can't just look at the needs because that's how the system runs. And the inflation rate of healthcare will continue until it's not driven that way. So as far as little things that will change, well, we'll do a lot more telemedicine, but we didn't do telemedicine before because it didn't pay. It didn't pay to be efficient. It paid to bring people into the office. So, yeah.
I'm just interested in all the interviews you did. Did you hear anybody talk about payment? Did you talk cost of care?
No, it's really interesting. And I've talked to people in a wide range of situations. No and no, because right now everybody's just on the front lines pitching. You know, I've seen the dire headlines about how many practices are going to go out of business and how many rural hospitals are threatened by this and so on. But for right now, everybody is saying, we've just got to get through this. Then we'll figure it out.
How do you want history to remember not only this COVID event, but how should history embrace our interviews?
I think the wonderful levels of compassion and creativity that reside in all of us, certainly in everybody I've interviewed. Yeah. And given that, I hope we're looking back in retrospect and saying, aha, we finally figured out we need to have a system that actually harnesses that puts that first. We'll see.
It's amazing times, my friend, amazing times.
I agree.
I couldn't have chosen a better partner to work with and really trying to get at the heart and the spirit of people who are impacted, and everyone's impacted.
Yeah. Likewise, you've got big doses of head and heart, and
So let's do this interview again in 6 months.
Okay.
6 months from now, let's sit down and we can answer some of the questions that we don't know now.
Mm-hmm.
You know, where will this take us, and what do we do with this incredible wealth of stories? Yesterday we spoke to two very bright young men, either of which could have been my son, and they were talking about maybe making these into a podcast, and maybe podcast technology is where we want to go. And I don't know. I would like to think of this as just our beginning.
I do too. And I think too that along with the sequester, or just all the people who are out of work or whatever, it's really, and there aren't sports to watch. It's really been a pause. It's a chance for reflection, and we've done it individually and as a culture. Less so healthcare providers, because they're just so busy just taking care of people. But it's been an important pause.
Indeed, it has. Anything else? Any words of wisdom before we wrap up this?
I think I've about used up my words of wisdom for this hour.